and we are so excited for the 15th anniversary of our Fight for Air climb. I am joined today by Amy Brown, who is our Fight for Air climb event manager. And Amy, how long have you been with the association now?
This will be my fourth Fight for Air climb, so I've been here since the fall of 2018.
Excellent. So Amy is a veteran. I was trying to remember if it was 4 or 5 years. And of course, we're joined by several people on our volunteer leadership team, some of our climbers, and definitely feel free beyond today, after the recording comes out, to share this great information that we have lined up for you today with your fellow climbers and people who could really use this information. We're really excited today. So let's go ahead and go to the next slide. All right, so Amy, I'm going to pass it to you to talk about why we're here.
Absolutely. So we are so excited to be back at Exploria Stadium on Saturday, February 19th. Our first climbers will hit the stairs at 8 a.m. We will be doing a staggered wave start time. And of course, Orlando City and the Orlando Pride often play at Exploria Stadium, and we are very excited to be climbing up and down those iconic purple stadium stairs, going through the supporter section and running across the field through the players tunnel for an approximately 1,000 stairs, and that's counting ascending and descending steps. So as I mentioned, we'll be having staggered wait times and wave times and arrival times, which will be announced on February 14th. Masks will be required at the event, but they are able to be removed during your physical climb. And volunteers are still needed on event day and on event week. We are also actively meeting as a climb planning committee. So if you're interested in volunteering on a larger scale, we're definitely open to that conversation. We would love to have you involved. Right.
All right, so I have the distinct pleasure of introducing our friends over at Applied Ingenuity Diagnostics for our mission moment. And we're really excited to have these new partners on board with the Fight for Air climb and partners to the American Lung Association. And they are very local, based right here in Orlando. And we really started to connect specifically on lung cancer when our conversation first started. But I know there's so many ties to lung disease in general that we're just really excited for how many areas within our mission this partners up on. But today we're going to be focusing on lung cancer and genetic risks. So I know a lot of you have expressed how excited you are to learn about this. And without any further ado, I'm going to hand it over to Dr. Shah over at Applied Ingenuity Diagnostics.
Hello, Janelle. Hello, participants. Thank you very much for allowing me to present today. I'm Maulik Shah, so I'm an MD PhD. My training is in internal medicine and clinical genetics. So my tie to genetics is quite strong as a background, and as an adult geneticist, one of the areas that I would see patients for is cancer predisposition syndromes. These are syndromes where one has a higher risk of developing cancer, and that's kind of what we're going to talk a little bit about today. I think many of you have probably heard of BRCA and breast cancer susceptibility syndromes because the Susan Komen Foundation does a very good job of educating people about that, but not as many people know about cancer predisposition syndromes relative to lung cancer. And although I'm not going to talk about general lung disease, there are other lung disease associated genetic conditions as well. I also have a personal tie-in to this in that my wife is an oncologist at the Veterans Administration Hospital in Lake Nona, and her specialty is actually lung and head and neck cancer. So she sees a lot of patients with lung cancer on a daily basis and manages their care. And she often emphasizes to me that even though lung cancer deserves a great deal more emphasis, there often isn't, and we need to do a better job just as a community of educating people about lung cancer. So I'm just going to take on one little point of that. Amy, if you move to the next slide. And this is a very short presentation. Some of this is just background, but I think it's worth reviewing overall. As you're probably well aware, lung cancer remains the most commonly diagnosed cancer worldwide, and it's the leading cause of cancer death. One of the things my wife often tells me is one of the difficulties she has as an oncologist is that her colleagues often will see patients and individuals who come back a couple of years later, and then she has these very friendly office visits with them. And she says, unfortunately, my patients, because lung cancer has such a high morbidity and mortality, I don't get to see them very often, even despite the best treatments. And so lung cancer is definitely an area of focus. As you can see overall, the dark shaded areas represent really parts of China and Russia where lung cancer incidence in males is especially high. But if you look across Latin America, like Brazil, and you look at North America, USA, we still have quite a high rate of lung cancer and lung cancer death. Amy, if you go to the next slide. And then this emphasizes the point that I was kind of making earlier, that the incidence of lung cancer is strongly tied with the mortality of lung cancer. And so unlike many other cancers where the cancer is often becoming more of a chronic disease where one can have that cancer and with appropriate treatment and management live a very fruitful life. Lung cancer, not to say that people can't, but lung cancer definitely still is kind of one of the more potent cancers to have. And you can see that the incidence of lung cancer is very high based on the graph I just shown previously, very many places, and the mortality is quite high. Interestingly enough, Amy, you can go to the next slide. Lung cancer is decreasing in males, but is increasing in females, in women all over the world. So regardless of geographic area, and the numbers are probably going to cross where the female lung cancer rate will equal the male lung cancer rate probably in the next few years. I think this is a very simple slide, but of course, we can't talk about lung cancer without talking about the risk factors and the incident risk associated with smoking. So as you're probably well aware, the major risk factor is tobacco use, and now added to that is probably air pollution, especially as air quality is decreasing all over the world, and especially in many large cities. Florida, interestingly enough, our air quality is not too bad just because we happen to be a peninsula and the way the jet stream and the winds work. But I was in like Santiago, Chile, not too long ago, and it's interesting. It looks beautiful, but if you climb any of the peaks around it and you look back into the valley at the city, their largest skyscraper in South America is there in Santiago, and you only have to climb like 4,000 or 5,000 feet before you can't even see the skyscraper anymore. So it highlights that although we're not aware, air quality is becoming a huge issue. Now, you see these graphs, and the bulk of the risk is tobacco related. But if you notice, the numbers are 80%, 85%, but that means 10 to 25% of all lung cancer occurs in people who have never smoked. So there's no smoking causality to that. And that's still a very large number. In fact, as a scientist and as a physician, we often now categorize lung cancer among never smokers as almost a completely different category than lung cancer in smokers. It almost acts differently. The genetic biomarkers are a little bit different. The pathophysiology is a little bit different, and we'll talk about that. But just to give you an idea of that 10 to 15% and how important that 10 to 15 or 10 to 25% is of that lung cancer in never smokers, if you consider just lung cancer in people who have never smoked, it's still more common than cervical cancer, pancreatic cancer, and even prostate cancer. This is a huge number that does not get the education that it deserves. So just that little piece above that bar graph would still represent a significant number of individuals. The other issue when we think about lung cancer in never smokers is that it tends to be diagnosed in people who are younger and tends to have a female preponderance. And we're not sure of the complete basis of that. There is a genetic basis or a component to that, but some of that is still being elucidated. Amy, next slide. Amy, next slide, please.
Yep, technical difficulties here. There we go.
No problem. Okay, so I did a study that we published, I won't tell you how long ago. And in that study, what we had done is we had asked women what they thought their breast cancer risk was. And so recognizing that women get a lot of education about breast cancer from general media, other sources, etc., we just asked, like, what do you think your breast cancer risk is? Do you think you're at high risk, moderate risk, low risk? We asked all these questions. And interestingly enough, one of the conclusions that came out of that study is 90% of women were not able to determine their own risk. And there were interesting corollaries to that. So, for example, white women in general underestimated their risk. African American women tended to overestimate their risk. If a woman did exercise regularly, they tremendously underestimated their risk. And the reason is because they had this perception of being healthy, and so they didn't think about what the risk is. And so the reason I tell you that story is we're not very good as individuals in determining our risk for cancer, right? And we get bombarded with lots of mixed messages, right? Take your vitamins and you'll do well, right? I think about all the stuff my mom constantly tells me, and which I'm sure she's going to tell me over Christmas and the holidays all the time about what I should do to be improving my health. But a lot of that is not scientifically determined. So we do know that 90% of people are unaware of their risk or misallocate their risk, like I was saying before, where they either think they're at high risk and they're at low risk, or they're at low risk and they think they're high risk. Why is that important? Because this changes how they manage themselves, how they make decisions about their lifestyle, and then it also determines how they allocate resources for their own healthcare appropriately. So when we consider this is cancer in general, just not lung cancer, 10 to 15% of all cancers are hereditary, meaning that there's some genetic component that's inherited in a, if you remember those Mendelian squares you had to do in high school biology, right, with the big A, little a. So it means the cancer genes are passed on in that same way. 5 to 15% of cancers are familial. And by familial, it means there's a genetic component to it, but it's not directly inherited, or it's not directly correlated. So meaning your father may have a certain cancer, you may pass on a risk gene, but it doesn't mean you'll develop cancer. It just impacts the overall risk determination. And then 70 to 80% is sporadic, and this is the cancer that would fall under tobacco use risk and other risks. So the reason I tell you that is there are many people who are at risk who don't have a family history of lung cancer or other cancers overall. So, you know, the big issue is then how do we determine risk, and how do we determine if we're genetically at risk for developing a cancer such as lung cancer? Amy, next slide. So this, I think everyone is familiar with. This is, once again, breast cancer, and it just highlights that gene mutations increase your risk of developing cancer. So BRCA, if you haven't heard of them, this is a gene associated with breast cancer, and APC is a gene associated with colorectal cancer. So the background rate just sitting around for any woman to have breast cancer in her lifetime is roughly 10%. However, if you have inherited the breast cancer gene, your lifetime risk of developing breast cancer goes up to 81%. Similarly, for colorectal cancer, for any of us sitting or in this audience, regardless if you're male or female, your average lifetime risk of developing colorectal cancer is only 4 to 5%. In contrast, if you're born with one of the hereditary genetic genes, your risk in your lifetime goes up to 70 to 100%. Meaning if you have that gene, you're virtually guaranteed that you'll develop colorectal cancer at some point in your lifetime. So now we're just at the point where we're identifying a lot of these gene mutations, or what genes are associated with the cancer that we're talking about. And these are the cancer predisposition syndromes, meaning if you have this gene, you're predisposed to developing it. Amy, next slide, please. And so how does that work? I don't want to go into too much science, but I think it's important to have a little simple explanation. And this explanation comes from, interestingly enough, a mathematician named Knudsen. This is one of those slides that you probably had in high school biology way back when, and pretty much everyone in medical school has had. So we know there are genes that are what are called tumor suppressor genes. So in a way, they're protective against developing cancer. And when we think these pictures that you see, this little bubble, this little up and down, that represents a chromosome, right? And so our chromosomes are where all our genes are located. And we have a bunch of chromosomes, but they're all paired, meaning we have, let's just assume this is chromosome number 1. We have chromosome number 1 from our mother and a chromosome number 1 from our father. So let's assume the left one is from your mother, the right one is from your father, okay? Over time, what happens, so I'm looking at the sporadic cancer. Let's say you're a smoker, right? You smoke enough that in the cell, in your lung, what's going to happen is one of the tumor suppressor genes is going to get knocked out, or it's going to get mutated because of the cancerous effects of smoking. So now you've lost that gene, and it's represented by that chromosome being red there. And you go along, you still don't develop cancer because you have 2 genes, right? So the one from your mother's chromosome is still there and being protective. You've only lost 1. But now let's say you continue to smoke, or you live in a place where you secondhand smoke or air pollution or whatever, it can be even sporadic. You lose the second gene, right? Now you develop cancer, and you see that cell now becomes a tumor. So in hereditary cancer, it works the same way, except the difference is that first gene you're born with, right? So it didn't require tobacco use or anything else. You were born with 1 gene knocked out already because you got it. In this case, if the left chromosome was from your mom and your right from your father, you were born with that gene already knocked out. So doesn't mean you're developing cancer, but as you progress through life, there's just a greater likelihood that that second gene is going to get knocked out. And it may get knocked out because of environmental factors, exposure to air pollution, exposure to asbestos, ultraviolet light, whatever it may be. It may get knocked out. It may just be sporadic, but because you were already born with 1 gene knocked out, you're more likely to develop a tumor. And that's why in hereditary cancers, there's some interesting facts about them. They do tend to occur earlier, right? So if you think about it, colorectal cancer really starts after age 50, just using that as an example. That's why we all, once you turn 50, it's advised that you get a colonoscopy, right? You don't do colonoscopy starting in your 20s. Why? Because there's no point to them. The risk of colorectal cancer doesn't really increase until you're about 50. However, remember I showed you that if you were born with that genetic mutation, your risk of developing colorectal cancer is a lot earlier. So hereditary cancer syndromes tend to occur much sooner than the background population of the cancer. And so that's why it's recommended for those individuals, they actually start getting colonoscopies at 20. You've probably heard of many famous cases of people with hereditary cancer syndromes who are at risk, and therefore they can make healthcare decisions to impact that. I think another famous case that you've probably heard of is Angelina Jolie. Her mother died of breast cancer at a young age, like I think her mother was in her early 40s. And just to give you an idea, breast cancer, just like colorectal cancer, is not really a risk until you're about 45 or higher. And that's why our guidelines for doing mammograms in women start at around age 45 or 50, depending on which organizational body you listen to. But women that have the BRCA gene are at risk of developing breast cancer much earlier. And so her mother developed it much earlier. And so Angelina Jolie did the genetic testing, was found to have the BRCA gene. And so she opted to have double mastectomies done to essentially decrease her risk of developing breast cancer because she had seen her mother go through a very severe bout of cancer. So the point is, hereditary cancers, you see a lot of them in the family. So you'll see a lot of individuals with the same cancer in that family. You will often see individuals in multiple generations, meaning, your grandparents may have it, your parents may have it, you may have it, or grandparents, an uncle. You'll see it in multiple generations, and you'll see multiple individuals in any given generation. So you'll see, there may be the generation above you, there may be, 4 brothers, 3 sisters, and you'll see multiple people with it, right? Whereas the background rate, if you think about any of them developing lung cancer, would be relatively small. So once you start seeing either individuals that have cancer at a very young age, if you see multiple cancers in the same generation in a family, you see the same cancer occurring in multiple generations, those are all kind of red flags that there may be a hereditary cancer syndrome in your family. Next slide, please. So this just reiterates kind of what I was just saying. And so this is a typical family tree. And you see that, for example, you see number of individuals with breast cancer, colon cancer, ovarian cancer in different generations. So once again, hereditary cancers are different from sporadic cancers in that you usually see several affected family members, earlier age of onset, multiple generations affected. And then sometimes there's a pattern to it that you can see overall. Sometimes individuals with one or more primary tumors. So remember that 2-hit hypothesis, sometimes those tumor suppressor genes are involved in different cancers. So if you've knocked one out already, you may see in that same individual, they develop lung cancer and then they develop thyroid cancer. They develop lung cancer. And so you see multiple different cancers in the same individual. So those are red flags. And remember what I was telling you, that 5 to 10% of all these cancer cases are a hereditary, or there's a hereditary predisposition, and we undertest people overall. So very few people actually identify their risk. Next slide, please. So the genetics of lung cancer. So lung cancer is kind of interesting. It's a little bit different from breast and colorectal cancer, where there's very strong causal associations with those genes and the cancer. There is also in lung cancer, but in lung cancer, there's more genes involved. The pathways are a little bit more complex. And so oftentimes you need multiple different genes to be affected. And so without getting into too much detail, this just impacts the statistical risk. Interestingly enough, I think many of you have heard of EGFR. So this is probably one of the most important genes involved in hereditary cancer risk. It's actually one of the most important genes that's knocked out even in sporadic cancer, so not just hereditary cancer. And so a lot of the newer drug targets are against this gene. Many of you have probably heard of TP53. These individuals tend to have bone cancers, breast, adrenal cancers, along with lung cancer. BRCA we talked about, or I mentioned, where there's more of a risk for breast and ovarian, but interestingly enough, people that have the BRCA gene have a significantly increased risk of developing lung cancer as well. There's another gene called CHEK2. I didn't go into it, there's a few more, but these tend to be the most important genes associated with the predisposition towards lung cancer. Amy, next slide. So how does one figure out your risk for cancer? Remember, I told you 90% of people are not very good at determining your own risk. There's actually some risk calculators online, but for lung cancer specifically, the risks are associated with gender. So right now, male gender increases your risk, although as I mentioned to you, females are catching up and gender will no longer, or male gender will probably not be a risk factor. Age, of course, is a risk factor, and age is a risk factor mainly because the longer you live, the more you're breathing poor air quality over time, or more exposures there are for that first hit to happen. Obesity is a risk factor, hence body mass index is in there. Exposure to radiation. This can be natural radiation, but it can also be general radiation. So one has to consider this if someone for some other condition has gotten many chest x-rays or CT scans. It's also one of the things I consider in people who are strongly at risk. So for example, if you're genetically at risk, in some cases, I may counsel that you limit radiation, just because radiation could give you that second hit. I'll give you an example of that. I had a young child who had a different genetic predisposition syndrome where they were at risk for developing skin cancers, right? The common basal cell carcinomas, et cetera. And this young 5-year-old kid had hurt themselves. And so they got a simple x-ray just to see if they had a broken clavicle. And as a result, they developed literally like 1,000 skin cancers right in that area of the shoulder where the x-ray was. And it just goes to show you, because you have that genetic risk, any kind of environmental exposure can give you that second one. Family history, I think this goes without saying based on what I've been telling you about a hereditary cancer. So if you have lung, but one should consider other cancers as well. I told you about some of the other genes involved where the risk is actually greater for breast, ovarian, other cancers. So one really should consider all the cancers in the family, but one should look at a family history overall cancers. Smoking, I think, of course, environmental exposure. So we mentioned air quality. This becomes also particularly important for people that work in industrial areas where there may be exposure to solvents or chemicals. Firefighters, may be at increased risk. Workers that work with insulation. And not just asbestos, but even the modern insulation has the small fibers. So technically, you're supposed to wear like an N95 respirator, etc. But I've seen very few roofers actually ever wear one when they're working. But so one needs to consider many different environmental exposures. Obviously, any history of previous lung cancer or other cancer in that individual. And then lung diseases. This is a difficult one. So there are lung conditions like cystic fibrosis, which do not increase the risk of lung cancer. But in contrast, there's other primary lung conditions or conditions that impact the lung, like sarcoidosis, idiopathic pulmonary fibrosis, et cetera, which also increase the risk of lung cancer, but are often people forget the lung cancer risk associated with it. So it's important to talk to a genetic counselor or a geneticist to really think through what an individual's risk might be, because that's the only way you can make good decisions about what the next steps are, right? So if it turns out that your background risk is only greater by 1%, it doesn't mean you should do anything different, right? In contrast, if you have one of the genetic risk factors, which means that your background risk or your risk now of developing, let's say, lung cancer or another cancer goes up to 50% in your lifetime, 60% in your lifetime, then you should really think about what are the next steps related to prevention, related to screening, and then related to management, right? What can we do to prevent it? So this is the big advantage of genetic testing is it provides you knowledge and education that you can use to manage your care. So going back to the breast cancer story, so if one has the BRCA gene, you can actually talk to your doctor and convince insurance companies that you should start doing mammograms pretty much in your 20s, right? But otherwise, if you actually went to a doctor or if you went to your insurance company, they wouldn't pay for a mammogram at age 22 because it's not within guidelines. It wouldn't be indicated. So similarly, like for lung cancer, right? So now we have some guidelines where we allow spiral CTs, but usually only for people with smoking-related risk. But you might convince someone that it's worth doing from the prevention standpoint if you knew you had higher than normal risk. And the reason for it is identifying cancer early is always better than identifying it late, right? So it's one of the big reasons oncologists stage cancer. So stage 1 of any cancer is always going to be better than stage 3 of any cancer. So identifying cancer early always gives you a better opportunity to manage and treat it appropriately. So it's important to really, if one is concerned, to talk to your doctor or talk to a geneticist or a genetic counselor about your risk of cancer. Maybe just not lung cancer, but any cancer. Amy, next slide. And so we make things a little bit easier because we found through experience, and not just our company, but there's other companies that do genetic hereditary cancer predisposition testing. And one of the things we found is it's hard to interpret these tests appropriately, right? So let's say, because there are companies that, for example, will only do the EGFR test. So let's say you think you're at risk, you have a grandfather and then aunt with lung cancer, and so you're making a strong story that you may have increased risk, but you only do the one EGFR test and it comes back negative, right? Well, what does that really mean for you? How do you interpret that? And the reason for it is maybe you have one of the other genes, right? Maybe there's additional genetic risk factors. And so one has to be careful when you go and talk to a doctor about, getting a lung cancer test, for example. You got to make sure it's comprehensive and it covers all the genes that may contribute to your risk. So specifically relative to lung cancer, we actually run a cancer panel that covers risk for a whole variety of different cancers, including lung, but it includes about 30 different genes. And the reason for that is many of these genes, although not primarily associated with lung cancer, are still associated with the risk of lung cancer, if that makes any sense. And so that's why we run a much bigger panel rather than just a focused panel. So that's why earlier in my slide, I only listed like the 4 big genes associated with lung cancer. But as I said, there's many more that give you slightly moderated risks, but we still think it's important to test them. So we do a big cancer panel. But in addition, one of the things our company does, which is maybe a little bit unique, and it comes from the fact that I'm a geneticist, is we include the genetic counseling in the test ordering. And the reason to consider this is genetic information, once learned, can never be unlearned, right? And so you really have to think about whether or not you want to know before you know these things, right? Because it can have dramatic impacts on how you manage your life. It can have impacts on your family. Because, for example, if you identify, let's say you're at high risk of lung cancer because you have one of these genes, you automatically, right, have now determined that your sibling, your brother or sister, probably has a 50% chance of having that same gene, right? But they may or may not want to know. It gets complicated, right, of how you may manage your life. The other thing is, remember, this type of information is protected under federal law from the purpose of like healthcare insurance and healthcare insurance portability. But something like life insurance is purely a financial product, and they're allowed to use whatever information they have, right? So suddenly you get one of these panels, you find out that you're positive. Good for you. I think it's important because then you can do better things to prevent cancer, manage, et cetera. But at the same time, now you're going to be limited in your ability to get some affordable life insurance, right? So there's implications of genetic testing, not just for your health, but overall. And so it's important to talk to a geneticist or a genetic counselor in advance so you can go over the specifics of your family and what the risks really may be so you can make an informed decision about whether or not to move forward with hereditary cancer testing. Next slide. I think that's the end of the presentation. Thank you for your attention, and I'm happy to answer any questions, and I hope this was educational and answered at least some of the questions about the genetic risks of lung cancer.
Thank you so much. Oh, I'm getting it now. This was a fantastic presentation. I will say, encourage everybody to please come off of mute, or if you want to type in a question to the chat, you are welcome to. But I've heard several presentations over the years on genetics and how it ties into lung cancer, and I think you explained it so well, where it was very easy for somebody like me without a medical background to be able to understand it. So thank you. I think that was fantastic. Did anybody have any questions that they wanted to throw in? And Amy, I haven't seen anything come through in the chat. I just want to make sure that you haven't seen anything either.
I haven't, but I echo all of your comments. This was incredibly educational, and I'm really glad that we were able to have you on the call today.
Well, thank you. So we're one of the sponsors of the Climb for Cancer, so we'll be there at the event if anyone has questions at a later time point. Plus, Janelle and Amy have my contact info, so people are more than welcome to get a hold of me, and I'll happily address whatever questions I can within the scope of what I'm able.
Wonderful. And yeah, definitely, this will not be the last time we ask you to speak, because this was an amazing presentation. I saw Sylvia just put something in the chat. Amy, were you able to pull that up?
No, I'm not able to see the chat since I'm presenting.
It just popped up, and she said it was very educational.
Okay,
So,
thank you.
Thank you, Sylvia. Janelle, if you don't mind, as I mentioned, I'm attending the BioFlorida conference, and so I have to hop out for another presentation and meeting. But thank you once again, everyone, for allowing me to explain a little bit about the genetics of lung cancer, and I look forward to hopefully meeting everyone sometime soon.
All right, thank you so much. Enjoy the rest of your conference, and we will get your recording back to you. Thank you.
Thank you. Bye.
All right. Let's go ahead and go to the next slide. That was an amazing mission moment. I thoroughly enjoyed that. So getting into now why it is that we do the climb, I think Dr. Shah's presentation really encaptured some of the important reasons why we need to raise dollars, that we need more research for early detection. And I know from some other presentations I've heard that we are really scratching the surface when it comes to genetic testing and understanding risk. So that's just another avenue of why it's so important for us to understand these intricacies around these different diseases. So our goal for the 2022 Fight for Air Climb is to raise $110,000. And we're going to go on to the next slide to explain how we're going to do that. And I'm going to toss that to Amy to give you the tools.
Absolutely. So we are here to help you reach your individual goals. There is the $100 fundraising commitment per participant to get to the starting line on February 19th. So there are so many resources that are already available at your fingertips. If you've already registered, you now have access to what we call your participant center, where you are able to send emails, connect to your social platforms, including LinkedIn, Facebook, Twitter, If you download the Fight for Air Climb app, you also will have access to share with WhatsApp and even Snapchat. We had our first Snapchat donation come through a couple years ago, and I was just baffled that that is an option these days. So we really do make it easy to meet people where they are, and that's how we find success with fundraising. One of the easiest and most effective ways we've seen is through Facebook fundraising. If you set that up through your participant center, there are really easy steps to follow to connect your participant fundraising to your Facebook page. And people will donate for a variety of reasons. Either they really like you and will support whatever you do, or they have a connection to the mission that you weren't familiar with. We've had people donate large amounts of money and later come out and say, yeah, my grandfather had COPD, and we had no idea that they were connected to one of our climbers. So putting it out to your network, again, inviting them to join you either to participate or to donate on a platform that's comfortable for them. If you also download the app, you'll have the ability to send text message directly through the app too. So I encourage you to explore these options, and I also invite you to make a meeting with either myself or Janelle or both of us to find a fundraising avenue that works best for you and your network. There are, like I said, a variety of resources. These are just some of our favorites, and we can find the way to help you reach that $100 minimum or exceed it. All right. So once again, our goal is $110,000, and I'm going to pass it to Janelle on why we are raising $110,000 through the Fight for Air Climb in Orlando.
So we work extremely hard to make every dollar that we raise go as far as we possibly can, because we do have a mission, and our tagline, when you can't breathe, nothing else matters, that it truly embodies every aspect of the mission and why it is that we do what we do. If we are able to achieve our goal with the Fight for Air Climb in raising $110,000, these are just some examples of how those dollars are put to work. So that those dollars that are raised can help to fund one lung cancer discovery award. And an example of that, we were able to gift or grant a lung cancer discovery award 2 years ago to the UCF College of Medicine. So that funded a full year of research around lung cancer specifically. Those dollars can also help over 1,100 people to quit smoking through our Freedom from Smoking program. Those dollars can also help to fund 220 days of research that will improve the quality of life for people who are living with any type of lung disease, whether it be COPD, asthma, lung cancer, and the many other diseases that we work with. So we're very proud that over 90 cents of every dollar that is raised goes back to programs and services. So let's go ahead and go to the next slide. So we're not asking each person to raise $110,000, that we all just have a little piece of that puzzle, that we are aiming to raise $100 per person. Many of you that are on the call are great about going above and beyond that, and we truly appreciate those efforts. They are so needed. But just breaking it down to, okay, like, well, that's great. We're going to raise $100,000 as an organization, but like, what does it matter for me? So just thinking about your $100 that you're going to be raising, that can help in so many different ways as well. It can help recruit 4 participants to the largest ever millennial lung health study. By that, we know that lung disease will statistically develop in many of us, but COPD just doesn't show up one day. Some of the lung diseases that we deal with, tend to have their onset a little later in life, but something happens within us that is the catalyst for lung disease. So this is really looking at what is that catalyst? When is that starting for people? So it's really exciting work and really groundbreaking. Your $100 can also help 2 students to stop vaping. We know that we are in a vaping epidemic. It can provide a courage kit to a newly diagnosed lung cancer patient. And it also helps to support 3 patients calling in to our experts to the lung helpline who maybe have questions about COVID-19, not 10, but hopefully that's the last variation of COVID that we ever see. So let's go to the next slide.
All right. So while those statistics and seeing how far your dollars can go and our collective event dollars can go are incredibly motivating, we also have additional motivators in the category of swag. So a $35 self-pledge will get you the keychain wallet, and then once you reach your $100 fundraising, you will receive the event day t-shirt. From there, you have the ability and we empower you to go above and beyond your $100 fundraising commitment, and you will see an increment starting at just $175 additional swag items that you can earn. So I encourage you all to take a look at these amazing items, including like a North Face jacket and then JBL AirPods. There are some really great things to strive for here. I will say once you get to the tumbler and beyond, those items are not cumulative. So if you really want that North Face backpack, shoot your goal for that's $1,000. Sorry, it's really small on my screen, $1,000, and connect with us. We will help you get there. But these are just some additional motivational items to really further our mission and take everything to that next step. All right, Janelle, I will pass it back to you to talk about Wednesday, January 12th.
All right, so we are so excited for National Take the Stairs Day, which is January 12th of 2022. We're just a few weeks away from that. So I hope you all will mark your calendars to join us at Ivanhoe Brewing from 5:30 to 7 on that Wednesday to celebrate National Take the Stairs Day. We're planning a fun celebrity bartender night. We're going to have games. There's going to be some really fun things that we're going to be doing to help kick off the stair climb and National Take the Stairs Day. So stay tuned, watch your inboxes, and watch your social media for more details. So let's go ahead and go to the next slide. These are just, again, some key dates for you all to have on your radar. So always an open invitation for anybody who has more of an interest in what it is that we're doing, that on December 14th, which is this coming Tuesday, is our next volunteer leadership planning meeting, and we like to have a good time. So we'll be at Ivanhoe Brewing enjoying a frosty brew as we plan the Fight for Air climb, and we're also working on virtual call-in options for those that it's not feasible to attend in person. National Take the Stairs Day being January 12th, much more information to come there. We have 2 more all participant calls. So the next one will be January 26th at the same time, same place, and February 15th as well. We will be sure to also incorporate more amazing guest speakers in the program. So I think it's so important for us to have that mission component, really understand the why. February 18th, we will have packet pickup, so there will be more information to come on that as we get a little bit closer. And of course, the big day, February 19th, is the stair climb at Exploria Stadium, and we will be having an after party that afternoon at 3:30 that day at Orlando Brewing. So be sure to mark your calendars. You'll be able to get cleaned off, maybe come back out a little bit later for some awards and enjoy some time with one of our other local partners. So let's go to the next slide. All right, so Amy, I'm going to hand it to you to wrap it up.
Sure thing. So from here, I hope you found this presentation incredibly informative in terms of why we do what we do and how we do what we do. So I encourage you to use this to register and motivate yourself and your team. If you haven't registered already, the website is open. It's fightforairclimb.org/Orlando. If you are joining a team, you can find your team that's already listed. If you're starting a team, go for it. It's all there for you. And then I do encourage you, as the year comes to an end, to jumpstart your fundraising through Facebook and/or sending emails. We see a lot of generosity at this time of year, be it for tax purposes or the warmness of your heart. People feel inclined to help support causes they believe in. So this is a great time to start your fundraising and ask your network to support you. We are just over 70 days away from the climb, so this is the time to really start your your efforts and make it an easy transition into the new year in terms of your fundraising and getting everyone rallied up and excited for the Fight for Air climb. And as always, our vision at the American Lung Association is a world free of lung disease, and through events like the Fight for Air climb in Orlando, we're going to make that possible. And I'm going to close out of my presentation here so I can help answer